So we're back, and the reason that we always give just a couple minutes at the beginning is just to get everybody on board, just to give you time. And it looks like we've got a full house right now, so it's our perfect time to get started. Welcome back. We are working on 2 webinars a week. It's a more ambitious project than I thought. Being in the office, seeing patients, and also trying to get 2 webinars, it seemed easy when we first came up with it. So I think we're still on track. I think we are actually 2 per week. I don't think we've missed any. We have had to change our times a couple of times. It was ambitious for us to think that we could do it by 10, but we have been able to jump on by 12. I'm Amy Jaramillo. I'm the Scientific Director of Body Science, and I'd like to welcome you back.
I'm Kyle Jordan. I'm the Nurse Manager of Infusions here.
And this is our 4th or 5th? Sixth, maybe it's 6th. We're somewhere between 4 and 6 webinars. And here is our mission. Both Kyle and I have MTHFR, and we both treat people that have MTHFR. And at the beginning of the year, we were giving some thought to what we can do to really improve the level of treatment when it comes to MTHFR everywhere. And it's not bringing everybody into our clinic. That can be limiting. So instead, it was really the idea of putting education out there. Unbiased is what we try for, scientifically driven information based on the experience that you and I have working with patients that have MTHFR.
Exactly.
And having personally dealt with MTHFR related issues personally and with family members. And so we'll continue to keep bringing more and more MTHFR information out there. We had on our original schedule planned to meet with Dr. Farrow, OB-GYN, to really look at MTHFR and its role in fertility. But we've realized the area of fertility, the topic of fertility, is bigger than a single webinar. And so what we realized is when we finish the general education, these basic courses, we'll actually launch a group of training, but specifically in the world of OB-GYN fertility as it pertains to MTHFR. And so rather than, again, just interspersing 1 or 2 webinars in this group of 8, we realized a lot of you folks are dealing with fertility related issues, both men and women. And for that reason, and because it's such an important topic, we will focus on it in a concentrated fashion. And so look for it in the upcoming handful of weeks. We'll announce ahead of time. We normally make announcements in the Facebook group for MTHFR, so MTHFR experts. So keep an eye out over there and we'll roll it out. We decided today one of the best things we could probably do is present a couple case studies. 2 very different, both women with MTHFR, one that's more along the lines of reproductive hormone dysregulation, so estrogen, progesterone, and the second that has more gut-related issues. We've talked about both, right? We had the last conversation on estrogen, progesterone, and a couple prior to that, we touched on gut. And so what made sense was really to look from a case study point of view at 2 people that have had those areas affected by MTHFR, and to give you an idea here in-house what we do to treat and get people better.
I like it.
Yeah. Okay, so today we start case studies, and we'll probably start doing more of these. We've gotten a handful of requests specifically for this in the form of questions saying, what can I use? What's going to work? Know that this kind of treatment oftentimes has to be personalized, but still we could probably do a better job of giving general overviews. And our easiest way to do that is to show you case studies, right, of people that we've treated. Yeah, and what we've used. And their initial symptoms. So with that, we start with case studies today.
All righty, let's pull up the share screen.
Perfect. Okay, so again, I'm Amy Jaramillo. I'm the Scientific Director here at Body Science. We are a functional medical clinic down here in Miami, Florida. We treat a lot of conditions, not just MTHFR. We got involved with MTHFR because a lot of people came in with random assortment of medical issues. And the commonality was that they were poor detoxifiers. And to say it differently, the commonality was MTHFR. So that's to say a lot of different people, a lot of different backgrounds, a lot of different heritages, all coming in with a number of symptoms and conditions, fibromyalgia and chronic fatigue, multiple sclerosis, ALS, Alzheimer's, Parkinson's. We kind of saw the full gamut. And the question was, what's the link? Turns out, again, MTHFR was the predisposing risk factor, not for disease, but for being a poor detoxifier. And when it goes untreated for extended periods of time, then there's no surprise a disease can occur. And that, for me, created kind of a hyper focus in the area, not just disease, but cellular medicine, and specifically conditions of poor detoxification, and trying to prevent anything else from happening in the world of disease. And you? Introduce yourself.
I'm Kyle Jordan. I'm the nurse manager. As I always say every webinar, MTHFR has affected my life directly. I'm glad to be here, and this really is personalizing these care plans. I never thought it can get so personalized as to really just focus on one patient at a time, just how you did with me. And so, that same love and that knowledge, we want to get it out to everybody else. Like, let you know, it can be done. You just take it step by step, do it scientifically, methodically, but there is a way to get better. There definitely is a way to get better.
So at the beginning, it really does kind of feel overwhelming. It's like there's so many symptoms.
Between the toxins and the food sensitivities and the gut microflora and the vitamin D levels low and the hormone and the testosterone and it felt like so much. And I remember you just grabbed me. You said, hey, let's set priorities. Yeah. We'll do this one thing at a time and we'll get there. And we did.
Yeah. Again, MTHFR, it's not really a disease. It's a genetic predisposition. And so what it's predisposing somebody to is a body that just doesn't work well, right? So whether we had talked already, glands that can't function because they've accumulated toxins, so thyroid dysregulation, estrogen, progesterone, or testosterone dysregulation, or again, tracking all these toxins through a gut, so getting all those gut issues, gas and bloating after you eat, or really poor digestion, constipation, or diarrhea, or kind of back and forth. An immune system that's being mired down by all these toxins, so all the fatigue that goes along with it, and toxins in a brain, so that's going to look like anxiety, irritability, mood swings, poor focus, difficulty sleeping, and then all the other symptoms that can show up as a result of those dysregulations. Right. So, whether it's hot flashes, whether it's cold hands, cold feet, weeping all the time, feeling depressed, lots of aches and pains in joints, in muscle. So yeah, I think it can be hard to know where to start. I like to oftentimes start with the symptom that's the most problem causing. Mm-hmm. What's the thing that's really preventing you from getting into your life? Or sometimes, depending, I'll start with whatever the first symptom was that showed up, because we know that was kind of ground zero in the world of, the cell where things started to break first. And the thing is, don't feel overwhelmed. It's our mission, again, to start providing the kind of information that you need, the basics for MTHFR.
Definitely.
Yeah, so you can divide out the different areas that may be affected and look for a plan for each. And again, just small steps, deciding where the first priority is. Find somebody that you can work with. So whether it's a functional provider, whether it's a nutritionist, whether it's a healer, whether it's somebody that focuses on meditation, whether it's acupuncture, find your style, whatever your style is. Find your team that can help guide you through this whole process. There's a lot of great professionals in all the areas. So again, kind of find what works best for you. We're functional, so we love functional. And here's the thing, I don't even know functional as the right term. I would say we're cellular medicine. I think that for me is more of a clear definition. We're not really about the genes. We're not really about a specific organ. So it's not about, does your gut give you problems? Does your thyroid give you problems? But instead, it's cells throughout the body that have become inefficient, especially at the level of the mitochondria. And how do we start correcting that? And once we can get a handle on that, then we get systemic or body-wide improvement. And by comparison to a traditional approach of trying to focus on one area, the only area that has become the problem, can be tough, because MTHFR is in all the cells, right? And so the detoxification error is in all the cells. And so the energy level, the mitochondrial efficiency, the use of thyroid hormone, sugar and insulin resistant. You're looking at a systemic or cell-wide issue. And so, yeah, I like the idea of actually rooting down to the cell in order to get things corrected.
I like it too.
Okay.
Alrighty, so we're doing case studies today, guys, and we have two for you here, two actual patients who, at the end of it, presented the same way I did, didn't think there was a way out. They thought that they had felt like this for so long that it was almost normal, you know, and it doesn't have to be that way. So MTHFR case studies, here we go with the first one. Go ahead.
All right, so this was actually a woman that was in the practice, her mom, who had MTHFR. Her daughter was starting to develop a number of symptoms similar to her mom. Her mom referred her in. She was a 31-year-old female when she came in. She had both an A and a C copy. Her mom was the C. And her father's in the practice at this point as well, and he was the donor of the A. So this young woman, 31-year-old, comes in. She was a nursing student at the time and was thinking about dropping out because she had such difficulty with focus and concentration. The complaints that her mom had let me know about, and then when she came in, she described as well, mood irregularities, lots of irritability, and lots of weepiness. So she couldn't control mood. She had been diagnosed with depression and anxiety disorder. It didn't run in the family. The mom had kind of a touch of both. So again, the mom being a single C, right, so has some of these symptoms. The daughter now that has both an A and a C, so has kind of a more concentrated version of what the mom had. And it had become fairly crippling, right? So she was still able to get her way through school. She was still in a nursing program. You know, it's a really demanding program, right?
Yeah,
so
definitely.
She was still able to hang in there, but she was having more and more panic and anxiety episodes, especially around midterms and finals. And as well, she had a history of menstrual irregularities. So a number of cycles that were not 28 days, a number of cycles that were heavy and clotty. A common question that I'll ask people, women that are cycling, do you have to take anything when you get your period? Do you have discomfort to the point where you're taking a Aleve or Advil or Motrin? Just know menstruation periods should not be painful. So that's to say it's kind of average for a woman to have just a little tiny bit of cramping, not where you're staying home from work, not where you're staying home from school. Right? An average period is about 3 to 5 days. So what should happen is a first day that's usually heavy, maybe even a second day, and a period where it's going to last for about 3 days and then be light for the following 2. The reason I tell you that is because most women don't know what a regular period is. They just know what their period is, which makes sense, right? So pretty much every woman thinks that their period is a normal period. And I routinely have women that have these very, very significant menstrual dysregulations, routinely missing work or school, in so much pain, and don't even realize that that's not normal. And instead thinking kind of every woman has the same period. So when I say complained of menstrual irregularities, just kind of going through it, a period should be 28 days. So it is 28 days when the estrogen part of the cycle and the progesterone part of the cycle both take the proper amount of time, and ovulation occurs between day 10 and 12. And there shouldn't be crampy clottiness, just very, very slight. There shouldn't be a lot of pain. There shouldn't be doubling over pain. There shouldn't be a lot of nausea. You shouldn't really need to take anything. So just know, if you're somebody who has these kinds of symptoms, right? So the menstrual irregularities, and now let's call them that, right? Because it's not a normal situation, in combination with mood, so anxiety, depression, poor focus, poor concentration, feeling generally overwhelmed. And if you have MTHFR, then consider the fact that it may be an estrogen and progesterone related issue. All right. So a standard is to run estrogen, progesterone in blood. I don't dislike it. It is the gold standard, typically on day 3 after menstruation. What I would tell you is, if the average menstruation is 28 days, the way I look at it, the way, you and I always see it when it comes to folks that we're treating, think about a puzzle, like actually going over to a store and buying a puzzle that's 28 pieces and not looking at the picture on the front of the box. And then I shake up the box and you take one piece, right? And you hold it up, right? You've never seen the picture on the front of the box, and you look at that, and it's whatever it is. It's like a smidge of blue, and it's got some yellow. And imagine I say to you, "Hey, Kyle, what is this picture? What is this? What is this little smidge of yellow and blue?" And then you start guessing. Whatever. I mean, maybe it's a sailboat with a sunny day. Who knows? Maybe it's the flag of a country. It's almost impossible to know. So for me, when you take a 28-day cycle and you try and take one blood test from it, it can be a challenge because even if that day is normal, it doesn't mean other days aren't dysregulating. Even if that day is dysregulated, it doesn't mean that other days aren't normal. And so when it comes to properly correcting hormones, for me, I like an 11 sample. For that reason, I'll use saliva testing. One caveat, if you are a woman that is currently on hormones, 11 sample or saliva testing is not accurate. It can't differentiate endogenous from exogenous. It can't see what you're taking. And so you really want to be unique to hormones when you're going to take a saliva test. And you can take a different number of saliva samples over a month. I just happen to like 11. I've done 6. I've tried 3. The fewer the samples, again, the fewer the puzzle pieces on that 28-piece puzzle, right? So for me, if I can at least get 11 of them, the rest becomes pretty clear. All right, let's take a look. Okay, you're looking at this patient and her levels. So I'll tell you, the first is estradiol. The bottom is progesterone. And then as you look at this, the dark, so let's look at the top one, that dark tealish mint green color, the darkest version of it is ideal. It's where you belong. It's in range and in the ideal range. Okay, the second lighter green around it is slightly outside of range, or at least one standard deviation outside of optimal. So it's still considered kind of reasonable and range-ish, if there was such a thing, but it's not optimal. And then when you're seeing those lines outside, like those first 2 points, that's entirely outside of range. And so what you should have is a group of points. Each point represents a single day where saliva was collected and the level of estradiol, which is a version of estrogen that's measured. So there's no mistaking the fact that there's a dysregulation, and I'll tell you below is progesterone. All right. So here's what should happen. The level of estrogen across the bottom, you're looking at days. So day 0, this collection started on day 3. So you're looking at the first collection, day 3, the second collection on day 5. And what you're seeing is as a woman comes up to ovulation, that gentle increase in estrogen is what should happen. That's the ideal in the middle, or the really dark green. And then a slope down, and estrogen should be low for the rest of the month. What you can see over here is exactly how this patient described herself: estrogenic and feeling estrogen from a mood standpoint. She was overweight. She had a difficult time maintaining her weight and staying lean. Estrogen is going to make fat stores. Because estrogen makes the sense of PMS, mood swings, irritability. You can tell throughout the month. I mean, she just constantly felt it, felt weepy, felt like internalizing and feeling overly sensitive. So what you see is, I'll just grab this mouse for a minute, right over here. So this is day more or less 7 or 8. Estrogen really shouldn't be that high. So that's kind of the beginning in that month of feeling lousy. And when you look down on the blue side of things, so blue being progesterone, not only is she not in the ideal area with the exception of 2 of the 11 points, but here's the thing: estrogen and estrogen symptoms don't feel nearly as terrible if progesterone is around there to balance it out. We were talking about it the other day.
The ratios.
Totally, right? It's the relative ratio of things. So the difference between the absolute number or the relative ratio. So even though progesterone does not belong here on day 7, 8, right? You can see this curve is lower. Still, this woman wouldn't have felt nearly as estrogenic if a relative ratio of progesterone was a little bit higher. But she knows she's going to feel terrible all the way up to more or less here, which is day 18, 19, because she doesn't really have enough progesterone prior to that. So the curve for progesterone should have started increasing right after ovulation, right? So no surprise, if you look at the top or mid-green curve, you're looking at estrogen, right? So the peak is going to be that pre-ovulatory spike, day 10, 11. By day 12, it's coming down. And so no surprise, after ovulation, progesterone is going to kick in. So that's when you see progesterone levels starting to come up. So the couple of takeaways over here. First, just the complete dysregulation of estrogen. Not only is it too high as a concentrated or total amount, but it's happening in spikes or waves in areas of the cycle where it does not belong. Okay, and then thing number two, this sense of low progesterone, meaning progesterone should be increasing by day, 11, 12, right around here. You should see this curve coming up. You can see here is this woman, she's day, what do you say? That's probably around 16, 17, right over there. She's not even in the curve. So not only is she not in the ideal part, but she's not even a standard deviation away. Her level is way down here. And meanwhile, look at all the estrogen exposure she's already had. So she's going to feel super estrogenic. And then we had discussed before the symptoms of low progesterone, forgetfulness, fogginess, wake ups at nighttime, and difficulty sleeping, the sense of feeling overwhelmed. I would tell you, in the men and women that I've seen that have low progesterone, it can make them rock stars. So it can very definitely hyper focus somebody. I've seen a number of CEOs, both men and women, that have low progesterone because they're so geared into do this. They can never get that thing out of their mind. I would also tell you, in my experience, it's one of the more common causes of eating disorders in both men and women. I've had a large number. I'm just kind of thinking of the number now, at least 20, more than that. I just don't have a firm number of young women with eating disorders. So either binge eating, I've seen a lot of binge eating, and I've seen a lot of women that are choosing not to eat, but binge eating even more commonly when it comes to low progesterone. Again, it makes the sense of an idea that gets into your mind and it just kind of sticks there. Again, it can make people very powerful workers, the kind of worker that never stops working. And as well, so going in the positive and going in the negative, it can move people into the direction of almost being compulsive about a specific thing. So whether it's working out or whether it's eating or not eating, or whether it's picking and doing things like that, low progesterone can actually do that. So remember, again, the reason that we're putting these MTHFR talks together, just to give you an idea of how MTHFR can play out and what these symptoms can feel like. So I think a lot of people feel like they're kind of on an island. I think before, for you, not knowing that you were MTHFR, you kind of look at the things that you deal with and you just either assume everybody has them, or you figure, why do I have them? How do I ever get them under control?
Yeah. A lot of what you were saying now really brought me back to not actually moments where I didn't eat until I finished something. I just refused to until I would actually finish what I was doing. And then I said, okay, now I can eat calmly. Kind of irrational now that I think about it. And actually, just the other day, I was actually between multiple activities, and normally I wouldn't sleep and I wouldn't do anything until I get those done. And for the first time in a long time, I actually said, I think I can reprioritize this part till tomorrow, and I'll be okay.
Yeah.
And I was.
Yeah.
And that break in that train of thought was actually really different for me, to be able to actually take a break from something and say, this can actually get done later. Let me, finish this over here, and then I can actually relax.
Yeah. So here's something that's interesting. Again, I've had a number of CEOs that have MTHFR and are low progesterone. And one of the common concerns that I get is whether or not properly regulating hormones would make them less successful. And so I would tell you, I think we have the cortisol curve of this patient. Did we include that, or we didn't?
Not sure.
Okay. It was totally flat. So my point is, nobody can work like that, right? Without extreme burnout. And so the question is, can you be successful without the kind of burnout that can occur when you become so singularly focused? And the answer is, yeah, you actually become better. You become better at life. You can become better at the things that you're doing, better at jobs, better at your passions. And the reason is because you're not so burned out. So if in fact you are one of those folks out there that is working with that sense of ruminating thoughts, right? Again, it's an idea that gets in your mind about the next thing with work, or the next thing with work, or the next thing, and you just can't shut that off. Right? Be aware, what's making you successful isn't really that. What's making you successful is the person that you are and the way that you think, through strategically. Yeah, thanks. Strategically, that doesn't change the fact that you're burning yourself out with kind of the low progesterone ruminating thoughts is not good. And so I don't want anybody over here being worried that if you start modifying hormones and putting them back into balance, it's going to make you less successful. It doesn't. Instead, it just makes you more balanced and generally feel better. And so again, just kind of looking at this curve, progesterone, the total amount was too low. You don't have that number. It just didn't fit on the slide, but the total amount is too low and it's completely dysregulated starting at day number 12, right, where it just doesn't start increasing, and estrogen is dysregulated throughout. So we'll show you now the treatment strategy that we used, and it was very effective. Okay, the reason that we started her on a P5.0 detox was to start reducing the amount of estrogen. So we needed a methylation approach. So remember, can we see the estrogen curve one more time?
Absolutely.
Remember, guys, MTHFR is going to affect estrogen levels because estrogen requires methylation. So what you're seeing on the progesterone side is ovaries that just aren't making progesterone early enough into the cycle. What you're seeing on the estrogen side isn't that. What you're seeing is the fact that estrogen is made and is not properly eliminated because the methyl donors, right, that bind and reduce estrogen just aren't available. So you're looking at two very different consequences here. Again, one is just ovarian turn on and a disconnect, right, between the ovaries saying, hey, or the pituitary rather, saying ovaries make progesterone, and the ovaries saying, I'm not ready to yet, versus estrogen, where you have this production, the ovaries turn on, and you can't methylate the stuff out. So you have this ongoing active estrogen after it should have already been removed. So in this case, we're going to always start with a methylation MTHFR detox. And we're going to do that to bring down estrogen. And the reason is we're going to start treating with progesterone post-detox. And then the question becomes, if this is where estrogen's at and this is where progesterone is, now we've got two options, right? Mm-hmm. We can try and balance it by bringing progesterone up to here, or we can bring estrogen down and then balance it by bringing a small amount of progesterone. So what's physiologic is not taking this high estrogen and then trying to boost progesterone up to match, right? Now what you have is two excessively high hormones, and that's not good. It's not good for you. And so imagine our alternative is reduce the amount of unwanted, unmethylated estrogen. It wouldn't be there if this young woman didn't have an MTHFR mutation. Okay, so we remove what doesn't belong, and we do that by methylating and detoxifying. Then we add a bioidentical sustained release progesterone. Bioidentical because folks with MTHFR don't do well with synthetic. Sustained release because the fact that it's bioidentical doesn't mean that it looks physiologic. It's physiologic if it's released slowly. You dump a bunch of progesterone into a woman that's cycling or a man, and what you get at that point is a lot of damaged receptors. So we start on day 11 until day 22. If we can see the other curve one more time. Okay, so you can see by day 22, natural progesterone has already kicked in, right? So we're not trying to add to that, otherwise the level would be too high. And as well, we're not trying to start it before progesterone is naturally going to start increasing. So by day 11, you assume again, ovulation, day 10 to 12, more or less. Day 11 is where you'd expect progesterone to start increasing. And so that's where we're going to start it. And sometimes for us, we'll use one dose. In this case, with this young lady, we used a higher dose on day 11 and all the way up to day 20. And then decreased over there because we just don't want a lot of progesterone when she's going to start making her own natural progesterone.
Right.
Calcium D-glucarate plus. So we were talking about this the other day on intestines. You want to talk about it?
That's okay.
Okay. All right. So calcium D-gluc. Again, here's the long and short. Remember, glucuronidase is an enzyme that is in the intestines, the large intestines. And what happens is when you have inflammation in the intestines, glucarate goes up. And so the thing is that has a number of purposes. One, a secondary consequence, unintended, but there nonetheless, it can recycle hormones. And so it can recycle things like estrogen. And so in individuals that have gut inflammation, they'll normally have elevated glucuronidase levels. That enzyme will be higher because of the inflammation. The inflammation turns it on as a secondary unwanted consequence of that inflammatory enzyme. You can start recycling hormones that are designed to be removed. So remember, the liver is going to methylate estrogen and set it into the intestines for removal. The intestines should allow for proper elimination, but when you have that high level of that enzyme, you're going to potentially try and repurpose, reassemble that estrogen, throw it back in the bloodstream. So calcium D-glucarate is something that will stop by lowering that glucuronidase level. We were talking already. So let me just tell you, the goal of glucarate is not the calcium or the D. So glucarate is what we're looking to do to reduce glucuronidase. We need a sustained release. Otherwise, it's just going to be eliminated in the intestines, right? And so if you're trying to make a sustained release anything, you're going to have to tag a mineral to it. So magnesium and calcium are the most common. I like calcium just because healthy bones, healthy body. And so between magnesium as the mineral or calcium, I'll normally go with calcium. Again, it's just sustained release. So if we wanted to make, I don't know, what do you want to eat and make it last for a long time?
That's a lot of stuff. Honey?
Okay, so totally, we could take a drop of honey, right? And we could wrap it up in calcium. And it's going to take calcium a long time, like 24 hours to break down. So let's say that you dump honey into the intestines. Like I just get a tablespoon of honey, right? It's a simple sugar, right? It's a simple carbohydrate.
Right, exactly.
It's going to be in the bloodstream in no time. Let's say instead that I wrap it up in calcium. Now the body has to break down the mineral calcium first. It's going to take upwards sometimes of 24 hours. And during that time, the honey is going to slowly release. So we could actually take a simple carbohydrate, honey, and we could make it into a complex, sustained release carbohydrate by wrapping it into calcium. Okay, so again, the reason for the calcium in this is just to get a sustained release. The D is just looking at the handedness of the enantiomer. So I could call myself Amy right-handed if I wanted to. It's an accurate description. I happen to be right-handed. So D is just kind of the shape and the facing of this glucarate molecule. And so same thing as far as the timing, just like progesterone, it doesn't need to be there the whole cycle. For glucarate, we're not trying to manage estrogen during the entire cycle. We're certainly not really looking to reduce the estrogen when estrogen is proper in the first part of the cycle, right? So instead, what we want to do is day 15 to 28. Can we see the estrogen curve? So you can see 15 to 28. Estrogen doesn't belong there any longer. And so what we're going to look to do is just stop that recycling and naturally, gently bring that estrogen level back down where it belongs. Blood labs, we measured them monthly just to ensure. The reason that we didn't continue doing the saliva testing, saliva can be expensive, and as well, it can be a hassle. Getting up in the morning, collecting saliva before you do anything else, making sure that you've got a freezer close by. So meaning if you're traveling a lot, if you're somebody that does travel a lot, trying to get 11 samples in a month can be a hassle. And so between that and the expense, blood labs are typically covered by insurance, saliva testing is not. And so we measured after this monthly, and we did an initial baseline in blood just to measure the first level in saliva and be able to correlate those. We discontinued treatment after 4 months because at that point the cycle had been corrected, the symptoms had resolved entirely. There was no reason to keep treating. We were talking this morning. Who was it? Somebody that we did it was the girl with eczema.
Yeah, yes.
So she's MTHFR, has had eczema since age 12. She's in her late 20s at this point. And the question was, so we just treated her eczema resolved. And the question from Dr. Farrow was ongoing treatment. And the answer, we all realized there is no ongoing treatment. What actually happened was she became toxic from exposures at age 12. That's when eczema started. She's been toxic ever since. It's not that she was continuing to be sick. It's that she couldn't methylate out the initial toxins. And so once a correction is made, there is no reason to believe that somebody's going to get sick again. And so for that reason, we took her off of everything. We kept her on a really low level detox, shake in the morning and just 1 package of pills. And so it made me think about that because that's exactly what we did with this young lady, is that we did a maintenance just to keep things methylated. But there really wasn't anything else. And interestingly, I didn't put her on a lot. Oftentimes we'll do methylated Bs, we'll do CoQ, we'll do a number of other things, but we didn't. We kept her on calcium D-gluc when she felt symptomatic to use as she needed. We continued twice a year on the detox, and there was nothing else that she needed. It's kind of funny, huh?
Yeah. Prior to that, I remember her saying she hadn't had a relief in eczema formation
Yeah.
in so long since she can remember.
Right.
So that was really nice to see that.
Right. She'd taken a medication for a period of time, a tumor necrosis factor alpha suppressor. She came off because she was concerned about her liver. Young, right? She's mid-20s, different patient again with eczema. And I share the same concerns. The thing is, she would have had to stay on that medication indefinitely because the underlying problem was this toxic buildup. She was developing elevated liver enzymes.
Mhm.
Imagine already in her 20s. And the bottom line is she still continued to have eczema. It just wasn't that bad. And so it's not to say everybody with eczema can be treated with a detox.
Right.
It just kind of comes to my mind just because we're talking detox over here. But really the summary is, listen, if you have something and it's been going on for a long time, doesn't mean that it can't be treated, doesn't mean that it can't be reversed. It just means it hasn't been treated up to that point. But once it is treated, you may find you do not need any ongoing treatment or a maintenance program, but kind of a gentle, mild maintenance program. If you have MTHFR, you actually may be living out prior exposures. And
Right.
those exposures could have happened decades ago. And even though you continue to be symptomatic, doesn't mean that you have an ongoing process. It means the same toxin that got in and made you sick at the beginning is still making you sick. Yeah. To that point, our next case study isn't hormones, it's gut for kind of the same
Yep.
reason, huh? Let's take a look. Okay, walk us through.
So this is a 71-year-old female with MTHFR. Coming from the gut, a lot of her symptoms were low energy, anxiety, low libido, maldigestion, irritability, and the such.
She came in at 71. She wanted to be healthier and she wanted to make sure that she continued to be healthy. So here's what that means. It means that with age, there's more muscle loss. She and her husband are both active. She was continuing to be active, but wanted to make sure. So she didn't come in with a major medical issue. She didn't say, hey, can you fix this? She said in general, she thought that she could be better, feel better. She wanted to make sure that she maintained her level of activity. She wanted to make sure that she continued to age in a healthy way. She was not on any medication at that point for anxiety, but she kind of toyed with the idea because anxiety had been increasing over the years. The low libido was something that she wanted corrected. And she didn't come in saying, I'm so low energy, right? But what she did say is she didn't have as much energy as she'd like. So again, healthy woman that presents she has MTHFR, no major health diseases, no major health problems, no medication on board, just generally wanted to feel better. And so for her, the first place that we took a look was her gut. And the reason is, I don't know, the idea that the gut is a second brain, and we've talked about it before.
Yeah.
For me, gut health is critical. And so when somebody just is generally healthy, but doesn't feel quite as well as they could, the question after 71 years of who knows what you come in contact with is how healthy is the gut? And if we could correct gut health, would we get somebody back to health? And commonly the answer is yes. And this is not at 71, right? This is 21, this is 31, this is 41, this is 51. And if anything, the younger now, and the only reason, because there's so many environmental toxins. So
many.
Yeah, so for somebody that is 71 today, they may have lived a good majority of their lives without a lot of exposures. And then if you think about some of the changes that occurred in the 70s and since that point, 80s, 90s, and into the 2000s, the amount of pesticides, the amount of toxic chemicals have gone up substantially. And I know the EPA continues to modify their standard of what's safe, oftentimes reducing those levels, or saying this differently, allowing increased amount of toxins and putting those into categories that previously, so by 1980 standards, for example, would have been considered something that was not safe. But now, as standards continue to be modified, as more toxins are in the environment, people are really coming in contact with a lot more things that previously would have not been allowed or would have fallen into the category from an EPA standpoint of toxicity. So this lady comes in, she's 71. Show us her gut.
Let's see.
I would tell you guys, it looks ugly. Okay, so we're looking actually at her report. So you can see, first of all, on the top category, so we go through a couple different things, but the first category, gut health and nutrition, the assessment levels of several key nutrients are too low. we know our steps moving forward. Gut overgrowth is a problem. We need to increase nutritional absorption. She has mercury. We'll show that to you. So we need to eliminate exposure. We know we need to replace B vitamins, and we'll show you how we did this kind of stuff, and other nutrients that are too low. And then we know that we're going to, at this point, run a 3-day stool to just kind of get a sense, a better name for these. You can see on the left side, you're looking at key nutrients. So the antioxidants, which are in that top group. So green being good or in range, yellow is too low, and red is high need. So in general, antioxidants look good. She looks the way she feels. She feels generally good. Alpha lipoic is a little bit on the low side, so we know to expect blood sugar dysregulation. Look at her Bs, right? So with the exception of a single B, let me just pull mine up as well. B7, everything else needs support. You can see just the sheer number of B vitamins that are high need. And we know this is a woman that eats well and is generally healthy. She and her husband have a healthy lifestyle. So once you start seeing these really low water soluble or easy to get, easy to eat vitamins, you know that gut absorption is going to be a problem. Minerals look good with the exception of manganese. When you go over to the right-hand side, what you're looking at is measures of malabsorption. The first, you see PAA, which is generic and just shows kind of an overarching understanding of gut dysbiosis or poor absorption. When PAA is elevated, it means you're not absorbing a lot of nutrients. You can see the bacterial overgrowth. Below that, you can see the fungal overgrowth. And then you can see the notes from our office, significant bacterial and fungal overgrowth in your gut, which causes malabsorption. PAA, the important marker of malabsorption, is substantially elevated. Vitamin depletions occur as a result. And then naming out the Bs. You can see our next steps for this patient. We will start the process to correct bacterial overgrowth. Once stool test results are complete, vitamins may be supplemented for 3 to 4 months as gut health improves. Eat foods high in B. So the same approach that we take with hormones is the same approach that we take with nutrition. We're not trying to get somebody on a supplementation protocol. We're trying to fix things and then get you back out to eating healthy, natural foods. You're always going to absorb more vitamins from food than you are from supplementation. So our goal is to correct and then get the heck out of there, right? And just kind of go back to your normal life. Let's see the next one. Oh, this is her mercury, right? So you're looking at packed red cells for mercury. So metal testing can be done in a number of different fashions. Because we're looking at it here in packed red cells, you're looking at more or less a week to 2 week window of time. So it's a substantial level given the fact that we're not looking at a lifelong exposure. We're not looking at hair testing, so that's about a year. We're not looking at urine testing, so that's about 3 months. So you'd be seeing the average of that length of time. Instead, we're looking at a couple of weeks, meaning if this is the average couple of weeks of mercury, you already kind of get a sense of how toxic this individual is. We know that mercury is going to have to work its way through the intestines. We know mercury is going to go into the gut. And so now we actually have a better understanding of why the gut dysbiosis, right? Why a healthy individual that eats healthy, right? That takes good care of herself, that has an active lifestyle, why does she have this degree of gut dysbiosis? And we know it now. We know it's because she's been consuming a diet that was high in fish. Her husband, as a side note, is somebody that has a cardiac family history and some cardiac issues himself personally. So this couple had decided what they were going to do was go almost entirely pescatarian, not realizing the amount of mercury that can be found in fish. So they moved away from a red meat diet almost exclusively to fish, veggies, and fruit, not really considering the risk of mercury consumption. And what she wound up developing was all this gut dysbiosis. You can see just right above that, the need for probiotics, the need for pancreatic enzymes. So again, it's a gut that's not functioning and a gut that has all this, mercury exposure and the resulting inflammation. And so poor absorption and even easy to get water soluble B vitamins as a result can't find their way into the bloodstream. And so remember, your key in this, do not just take a bunch of B vitamins. That's not the cure for this, right? That's not the solution. Instead, you want to fix things. We did a 3-day stool for that. And as well, you can see our note on the bottom just describing The fact that when a large intestine has this much overgrowth, PAA is this elevated, we know that we're going to see leaky gut. And so I think we have her leaky gut test here. Do we have it? Is that below here on the slide?
No.
Oh, we just went to treatment. Okay, so two things that we're missing. We didn't put over here her 3-day stool test results, and we didn't put her leaky gut test. What I would tell you is she had advanced leaky gut, severe leaky gut, to be expected. With the 3-day stool, we were able to identify the actual pathogen that was causing the overgrowth and treat it. And so let's take a look at treatment. So we, our first directive to her, identify and eliminate the source of mercury. So we actually had her modify the kind of fish, going to much smaller fish, and we retested in blood a couple of times after that until what we saw was ongoing exposure had been eliminated entirely. She needed bees, so we put them on in a methylated form because she is somebody that has MTHFR. We did it just for a short period of time. It was a 3-month window as we corrected the gut. We did eliminate the foods on the food sensitivity, so we needed to get her small intestine back into health. So we sent to her home a food sensitivity kit. It's just a finger prick. Got a clear list of all the foods that were adding to even more inflammation. I had her eliminate them. We did run a 3-day stool test, same thing, that went to her home. So she was able to collect in her home. We used that to, number one, determine the microflora, the healthy commensal microflora that was missing. And as well to identify the overgrowth in the bad bacteria. We cultured it. We actually found a natural strategy. So we found that it responded to uva urcean plant tannins. So if we can ever do natural as far as getting rid of pathogens, so in place of a traditional antibiotic, we'll normally do that. This is not, by the way, an editorial on antibiotics. What I would tell you is, and I've said this before, if you have an infection, you have to take antibiotics, you take them for sure. Infections can be really, I mean, you come out of the ER, so you know what happens when you leave an infection, you don't treat it. All bad things happen. At the same time, if it is something that can be cultured and proven where a natural approach is effective. So not just guessing at it, but we know that a natural approach is equally as effective. And we can see the scoring side by side. So a traditional antibiotic versus more of a natural remedy. And we can look from a scoring standpoint and ensure that both are going to be equally as effective. Then for us, we're always going to go natural. And we were able to with this lady. If we were going to go on an antibiotic strategy, what we would have done, if it is a pathogenic infection that has high risk of spread, then we'll start an antibiotic immediately. But if we're not in that situation, and we rarely are, we're rarely in a position where we're looking at somebody who's septic. And so we'll typically take at least 2 weeks prior to adding an antibiotic. We will increase D levels to make sure that they are robust. In blood, we will increase tocopherol or E levels, omegas, to make sure that they are robust in order to give the gut a little protection from an antibiotic. We'll also put on a specific formulation of probiotics that are designed to kind of hold on to and cover the natural commensal microflora so it doesn't get knocked around so much. And we'll do that for at least 2 weeks, sometimes a little bit longer, depending on the commensal microflora. And then at that point, we'll start an antibiotic. So for this lady, you can see the treatment plan. We finished and she had full correction. So it turned out that some of the low libido for her, it really was a result of just generally being unhealthy. Some of the other things, the fatigue, we were looking at mercury largely. And again, gut overgrowth. So our goal with both patients, right, get a really clear understanding, getting the test that we need to really know what's going on, treat, and then just move them back to a healthy lifestyle as far as eating well, taking good care of yourself, and not really staying on a lot of supplements long term. So the same thing, I would tell you, it's not an editorial on taking supplements, not taking supplements. We certainly use supplements over here, but if we can, we're always going to look to correct and then not really have a lot of ongoing. Bodies are resilient, right?
Oh, yeah.
And really good at using the diet, especially a rainbow diet, to get the nutrients that it needs. So keep in mind, supplementation should just be that, meaning you should get the majority of what you need from your diet. And that's what's going to happen if you have a gut that has proper absorption. If it's an absorption problem, fix that. And then rely primarily on your diet. If you need to supplement, and again, that's what that word is about, just a small amount of additional support, do that, but you shouldn't be living on supplements. We'll have people come here, and sometimes I'll ask them, hey, just bring in everything you have. I'll have people that tell me that they can't, not because it doesn't fit into a suitcase, because we definitely have people that bring in suitcases, but because they have everything so organized, like on a shelf of their, whatever it is, 20, 30, 40 supplements, that they don't want to take them down because then they have to reorganize them again.
Wow.
And I've certainly had people that come over with suitcases filled with all the supplements. Just know supplements have the same potential for interactions as traditional medications. And so even if one supplement is something reasonable, by the time you add the second one, you got to wonder, are they going to interact? The more supplements you have on board, the more likelihood of interaction, and the more interactions you have, the more potential side effects you're gonna feel. So the goal, again, identify the source of the problem, treat it, correct it, and then get back to kind of a natural, healthy lifestyle.
That's the goal.
Yeah. Okay, so I know there's a bunch of women stuff and a bunch of gut stuff, so we didn't really have a chance to talk very much. So I don't like that. I don't like that at all. Tell me, tell me your thoughts. What's kind of going on for you with this whole thing?
So I'm just I'm thinking about what I've had to do for myself. I guess speaking as a guy, I've been able to pretty much keep everything up, eating whole foods, and keeping my supplementation actually at a minimum. Yeah. And what I'm doing is testing regularly just to make sure everything is going okay. But I feel better than ever. And so as you're going through a lot of these, I actually think of the process I had to go through and what it was like for me before. Just how you said that, because it's been like that for so long, right? So for women who have these horrible periods, I know we have a lot that say, but that's normal because I've always been like that. Or, my mom was the same way. Yeah. Oh, it runs in the family. It's fine. It doesn't have to be that way. And I thought that it was like that for me as well, for guys, for certain traits, and say, well, I've just kind of been that way for a long time. It's like, well, it doesn't have to be. So it was just great to see a plan. It's always nice to go over plans of patients who have gotten better, to see how they came in and where they are now, and the relationship that we've built with them. So it's very nice to see where they are now. So
yeah, what do you think when you and I first got together? You were certainly taking a lot of things.
Oh yeah. Yeah.
So now, by comparison, pared down substantially.
Oh yeah, big time.
And then looking at how you felt before and how you feel now, compare them.
Okay, so let's see. So I explained earlier about the almost compulsive need to finish what I was doing. Now I can actually, I prioritize better. I feel just clearer. I feel that I don't have to get everything done today, right? I feel stronger. My workouts are a lot better. And I could actually work out a little bit longer. Sometimes I have to kind of actually put a stop to it and say, okay, I think I've worked out enough for today. This is good for your health, for body. I say, okay, I could take a step back. Planning time-wise, and just anxiety. I wake up in the mornings and I kind of already know it's going to be a good day, instead of kind of rolling around and wondering, oh my gosh, is today going to be like yesterday? Is it going to be? No, it's kind of especially when it pertains to balancing my hormones, getting that ratio correct. I have a lot more control over how my day is going to present, pretty much because my thought process allows for it now. Instead of saying immediately waking up and thinking, oh my gosh, I got to do all these things. Think about all the things I didn't do yesterday. I have my regimen. I wake up and today already looks pretty good. There's no reason to be anxious about it. No reason to be nervous about it. Yeah. And so it's a big difference. It's empowering also to know that resources are out there. That there are capabilities to test even at home. I didn't know about that, but especially now with coronavirus and everything going on like that, the ability to do telehealth, to do it from home, like it's never been easier. Yeah. So that's something that I try to tell our patients as well, and they know. Yeah. Zoom consults and things like that. So it's like just more than ever. Now is the best time to get control of this, for sure.
The reason, the difference between you and I is because you've recently been working on MTHFR. Mm-hmm. I had, but it was whatever it was, maybe 7-8 years ago. So I think when you describe it, I recall the same thing for myself. It's just, a longer time ago, so it's not front and center in my mind. But I think the same. And also, I think about shopping around. I'm sure a bunch of folks that are watching have done the same, where whatever you're trying to fix, so if thyroid is making brittle nails and thinning hair, then you're looking for a bottle that says get better hair. If MTHFR estrogen dominance is starting to make weight gain, then you look for a bottle that's like lose weight. So you start trying to find like a solution for each of the symptoms, and then you wind up just taking a bunch of things. I feel my best now, taking very, very little, just having corrected everything. And I know the same thing for you. Interestingly, we are both on detox right now. I started about 2 weeks ago, because what happened with me, my husband and I normally do detox together, and Umberto was working out. This is, I don't know what it was. It was about 2 weeks ago, and his knees were killing him. And the first time we ever did detox, Beto plays soccer every Saturday. That guy has a lot of wear and tear, soccer wear and tear on his knees. And we always know it is time to do detox because his knees will start to bother him. I think I told you, I have like a couple of fingers where there's like a joint that gets kind of achy and sore. So I wasn't even ready to start it. We typically do detox at the beginning of the year. But I was kind of in my own world. I hadn't planned to do it. And then it was in bed and he's like, we've got to start detox. And then I had mentioned to you, like whatever it was a week ago, I was like, I'm on detox. And then you started with your mom. Yep. You guys started. And then I forgot to bring in my morning shake the other day. And you were like, no problem. I've got shake, because we're both in detox right now. So you, me, your mom, my husband. And so I would tell you guys, it's not just something that we talk about, but again, being folks with MTHFR. Oh, I almost forgot this part. Somebody had asked, so we keep getting the question of whether or not there is something that can be done as far as for the people that attend the webinars, a special discount for the MTHFR store. I've gotten that question now. Our front desk told us like a million times, like, could we do something special? So yeah, actually, BiomeIQ agreed to a 15% discount on the P5.0 detox. And so I don't have a way to give you the code. I don't know how to give you the code because I don't remember the code. The code's at the front, actually. But for anybody that needs it, you can just email over here. They already know it at our front desk. I should have brought the code back and told everybody. I almost forgot entirely. I almost forgot the entire thing. Okay, so let me just say this again. The BiomeIQ P5.0 detox is 15% off right now for everybody that has attended the webinar. And so you're welcome to just email us and let us know that you need the code, and our front desk will send it over to you. The email over here is info@bodyscience.life, LIFE. So again, it's info@bodyscience.life. I think I mentioned already, we looked at a .com and realized we're about life. Like that's truly the case. We're about changing lives and getting people healthy. So we're info@bodyscience.life. And so anybody that needs that code, again, let us know. It was great talking to you guys. Do we have, what else would we like to say?
I think there's a way through. That's what I tell everybody. There's a way through. This can be very empowering, like it was for me. And we haven't said in a few webinars the superpower. This is a superpower, guys. It helped me to reframe what I have. And I think there are some theories circulating out there that MTHFR variation was developed actually as a response to increasing exposure to toxins, generation to generation. And so our ability to detect toxins and toxin exposure well before others
it's amazing.
It really is amazing. It really is amazing. Yeah.
So the thing is, for a lot of people, you are so toxic at this point that you just feel lousy all the time. And so coming in contact with the next toxin, whether it's a heavy metal or whether it's the chlorine in the water or whether it's, additives in foods, whatever it's going to be, you can't even detect it because you just are so snowed under, right? You already have chronic fatigue. You already have fibromyalgia. You already have achy joints. You already have chronic headaches. You already have like the sense of feeling anxious. So in other words, your MTHFR version is already, just fully amped up. But if that stopped, if you could clear out those toxins, then what you would find is that you have an exquisitely sensitive ability to identify toxins. And if you use that moving forward as your way to prevent ever becoming toxic again, then it is likely that you will always of course, live with MTHFR, but it will never become a problem because imagine the number of times, like I think for myself, before I knew that I had MTHFR, before I understood I had MTHFR, the number of times that I walked into situations and stayed in places that I knew weren't necessarily good, but they weren't a problem. I bartended through college. There was a lot of smoking in bars at that point. When I get in contact with cigarette smoke now, it's really uncomfortable for me. I'm sure it was then as well, but I didn't get the symptom, right? And the reason is because I already had all the symptoms. Like, so one more night of working and breathing in a lot of smoke didn't make me feel any worse. I already felt generally not as great as I could, right? So again, if I had it now, if I was clean enough back then, I wouldn't have stayed in that environment. I wouldn't have been able to, right? But instead, already being so toxic, one more not great day was just one more not great day. I didn't put the two things together. Now, if I walk into, I know COVID, so I don't get out too often, but if I walk into any place and they've got like a lot of cleaning solvents, that happened. My husband and I walked into, it was a ramen restaurant not too long ago, and they had like this huge odor of cleaning stuff over there. I guess kudos to them from a COVID standpoint, but I got to tell you, I walked in and I instantly felt like a little tiny bit of a low grade headache. I was like, oh no, I don't belong here. Like, so from a superpower standpoint, and we left.
Wow.
So it really is the case that MTHFR kind of gives us all a very, very hypersensitive way to know where we do not belong. And remember, most of those chemicals, they really are disease causing. At the very least, we know that most of them are cancer causing. And so the thing is, everybody that doesn't have MTHFR, they have those exposures, right? They have no sense that the exposure is really a problem, right? They're not getting the low grade headache. They're not getting the increased anxiety. And think about the anxiety and irritability, right? It's almost like a whole body that's saying, hey, not only do I not want to be here, but if I'm with somebody else, they're not even going to want to be here with me. They're going to make me want to leave because I'm so difficult to be around. I mean, it changes so many things. Oh, do we have a question?
No, it's a comment. We'll reach out to definitely.
Okay. All right. So anyway, yeah, I completely agree. I think, oh, holy cow, it's long. Stacy, thanks for writing. I don't know that we can get it. Do you want to give it a try? Let's see. Stacy, we'll read it and see. Okay. Just learned my lifelong symptom may have all along been linked to MTHFR. I'm now seeing a naturopathic hormone pharmacist in Oklahoma City. I haven't been tested yet. Keep asking. I have a very long health history, 14 surgeries. Wow. And really am ready to get started on this journey of figuring out if this is indeed my underlying issue. Where do I start? Right. That's a common question. Exactly. Okay, she's 46. She's got major gut issues after 4 abdominal related surgeries. She can't lose weight, past history of eczema, no energy or libido, already had a complete hysterectomy 16 years ago on a compounded Biest and testosterone cream along with progesterone capsules. Could someone possibly reach out? Yeah, so yeah, Stacy, listen, we'll certainly reach out. Going back to, I'm sure this sounds for a lot of people that are on similar to your situations. Yeah, I find hysterectomies are unbelievably common in individuals with MTHFR, or to say this differently, I have a lot of folks that come on in, they have a history of hysterectomy, and on testing, they are MTHFR positive. Again, it's the estrogen component. So if a woman is estrogen dominant throughout the majority of her cycling life, then fibroids, cysts, and unfortunately tumors can become common. And so for that reason, hysterectomies are a commonplace. One of the areas that I work on, we saw the first young woman with estrogen progesterone. Her mom had a hysterectomy. And one of my goals in working with the daughter was to prevent that from ever happening, right? So just know if you can get hormone control, there are a number of things that can be avoided that would otherwise potentially be kind of imminent in an individual with MTHFR. Stacy, again, what I would tell you is not only will we reach out, but let's find a starting point. It's good that you have somebody that you're working with over there. Let's kind of work in combination with them. What we'll plan is to schedule an appointment, get a really, really clear understanding of your history, get a really, really clear understanding of your medication, We'll do some testing for sure, right? The question is, where are your estrogen, progesterone, and testosterone levels now, especially because you're on that therapy, because you're describing gut problems. Already on our side, we're going to look to do things like food sensitivities. We're going to look to do things like a 3-day stool. If you have upper GI related issues, then we may even look to do like a small intestinal bacterial overgrowth evaluation. What I would tell you, this is very treatable. So you fall into the category of a lot of the folks that we see, a lot of the folks that are on these webinars, which is people that have been sick for a long time, have a long medical history, feel like maybe they're never going to get better. It's not the case. Just know the things that you're describing are incredibly treatable. They're incredibly treatable, okay, and they're very reversible. And so let's come up with a strategy. I'll see if I can't have my office reach out and give you a shout today. Okay. All right, guys. We will see you next time. And then I think our goal is more case studies.
That was great. I liked it. Yeah.
Okay. So if there's something in particular that you'd like to see a case study on, we can certainly do case studies on men. We have lots of men in the practice with MTHFR, testosterone, focus and concentration issues. So we can talk about that. We can talk more about case studies for thyroid, and we can look at thyroid labs and talk about those corrections, blood sugar. So now we can kind of go through some of the common outcroppings of MTHFR or detoxification, looking at patients, looking at labs, looking at treatment strategies, hoping that maybe that gives the kind of information that will be essential for everybody to get the kind of support that they need. So let us know, you guys. Again, we're on MTHFR Experts on Facebook. So if you have something in particular that you want to see a case study about, I know you always ask, and it really is true. We haven't seen a lot of people go over there and tell us. So we're on our own, just kind of figuring out what we think that you're going to like. I think we do go in the direction of case studies. If you have recommendations, definitely let us know. We're talking to you, right? I mean, so we want to make sure that we have your needs addressed. And then we'll see you next time. All right. Bye, guys.